My name's Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, and today we're very fortunate to be joined by one of the world's premier psoriatic arthritologists, Professor Philip Mease from the University of Washington School of Medicine in the USA. Hi Philip, welcome. Today we're going to be talking about the SELECT PsA2 trial that's been very recently published in ARD. But before we get started, Philip, could you just tell us a little bit about yourself and what your research interests are? We know that you're a very eminent PsA-ologist, in fact, former president of GRAPPA and life member of everything important in PsA land.
So thanks, Peter. I'm a rheumatologist practicing in Seattle and busy with seeing patients as well as doing clinical research. I help mentor young residents and junior faculty coming along in the world of PsA and psoriasis. And through this organization, GRAPPA, that you and I are both part of, we really do have a chance to touch numerous and interact with people all over the world who are interested in psoriatic arthritis. And I've had the fortune to be quite involved in, from a methodologic point of view in helping to design most of the clinical trials, including this one we're talking about today with this very interesting emerging JAK inhibitor, Upadacitinib.
Excellent. So let's just talk a little bit about the JAK market in the USA. How's it going in the RA world? And is it available in the PsA world? TOFA had a study not so long ago. What's the market like for JAKs, including PsA in the US?
I don't know the actual percentage uptake of use of JAKs, but I think they're popular in rheumatoid arthritis. And so most rheumatologists in the US readily use the various JAK inhibitors that are approved, which include tofacitinib, baricitinib, and upadacitinib. There is a fourth one that is in kind of hold-up pattern, filgotinib, which hasn't been approved. But and it's pending some safety data that they're readying for the FDA. So TOFA has been out for the longest and is used quite a lot. We use it in the once-a-day sustained release form. And it is highly efficacious in RA. It was approved in PsA a couple of years ago, and I've seen a real uptick in it because it's a highly effective agent in PsA, and people like using an oral medication. During the COVID pandemic, I haven't seen it either go up or down. I think people recognize that all of our drugs have been largely exonerated from being associated with either increased likelihood of acquisition of COVID infection or having a more severe course based on some of the long-term registry data that's been accumulating since early March. And so I personally, I find most of my patients that are currently on any of the JAK inhibitors are continuing with them and feeling fairly comfortable about it. The only thing I'll throw in is that we've more recently had some warnings about thrombosis with the either DVT or pulmonary embolus. This originally arose in the investigation of baricitinib, but it looks like it might be a small signal in patients at risk. And so that's something that we've had to talk about recently with our patients. I can't say that it's deterred them from using the medication or making them want to switch, but it is an additional part of the conversation we have with patients now.
Excellent. Do you, just from your background reading, do you think it's a JAK2 effect or a JAK class effect? That's the kind of key question.
Peter, I'm going to turn to you. I have a feeling you're more expert on this than I am, so I'm going to turn that question back to you.
All right. Well, let's plug on. Let's tell us a little bit about the rationale for this particular study.
So upadacitinib is a more selective JAK1 inhibitor. So, for example, it may not having as much JAK2 effect, it may not have as much impact on, negative impact on hematologic parameters, for example. And it has proven to be very effective. Its rheumatoid studies were very strong. In fact, in one of the rheumatoid arthritis studies, its 30 milligram dose bested adalimumab, for example, and its 15 milligram dose was similar to adalimumab in effectiveness. And we've seen in PsA, we've seen it be as strong in the musculoskeletal aspects of PsA, which includes arthritis, enthesitis, dactylitis, as the TNF inhibitors, for example. And interestingly, the data in the skin from tofacitinib and filgotinib suggested PASI 75 responses in the 45% range. Here we're seeing better results. So we're seeing skin results, which are up in the mid 50% range, even higher for PASI 75. Don't know why that is. I don't have a clear-cut idea, but I'm not going to look a gift horse in the mouth. I'm going to accept that and like it, and I'm sure patients are going to like it. The safety profile with the drug was similar to what we saw in RA. There was a bit of a dose-dependent relationship in terms of a little bit more infection in the 30 milligram dose than the 15 milligram dose, but there were no new surprises. And in particular, we didn't see, you worry in a psoriatic arthritis population about liver issues because patients may have fatty liver. And we didn't see that. We didn't see any real uptick of transaminase problems within the PsA population with upadacitinib. So strong data. And we wanted to show that, and we were able to show it with both in both a group of patients that were naive to biologic therapy, which was PsA Select 1, and then in the trial that I lead authored, which is the PsA2 trial, in which patients had previous exposure to TNF therapy.
Excellent. So Select PsA was lovely. The skin response was up there with TNFs, and it was really twice as good as we expect MTX, even TOFA. And you had imaging as well, which was very reassuring. So no imaging this current study, but can we just ask a little bit about the outcome measures? Should we be using DASH? Should we be using MDA? Did this study help us decide which of those measures should be the one to use in clinical trials, or do we keep going forever measuring both?
Good questions. So I'm partly to blame for the ACR response being the primary outcome measure forever. So back in 1999, 98, 99, I can't, how old were you, Peter, then? I designed the original Inbrel or etanercept trial in PsA as an investigator-initiated study. And I had just had to sort of go, well, what can we use as outcome measures? So I said, well, let's pull in the ACR 20 response as a primary outcome from the rheumatoid arthritis trials, and let's pull in the PASI score from the dermatology psoriasis trials. And we sort of cobbled it together. We didn't have PsA specific outcome measures at the time. And in that particular trial, it worked well. The FDA liked it, and they're a very conservative body, and so they really have wanted all trials subsequently to use the ACR20 as a primary outcome measure, even though it's primarily articular in focus and not more comprehensive, unlike the MDA. We did try to get the minimal disease activity, which includes enthesitis, skin disease, for example, as a co-primary in the SEAM trial a few years ago when etanercept was being compared to methotrexate. And the FDA even then said, not quite ready for it. We don't know that everybody understands it. We don't know if American rheumatologists really understand it. And so you can use it as a key secondary, they said. The EMA, which I think is more advanced in its thinking and more willing to look at what is really a meaningful response measure, are considering shifting to a psoriatic arthritis specific measure such as the PsA and having achievement of minimal disease activity as a key secondary. So we're still there with the ACR responses, but we collect all the others as well. So for example, in this trial, the MDA ended up being met by about a quarter of the patients in the trial, a highly meaningful number, achieving minimal disease activity. And we also measured individual musculoskeletal responses like enthesitis and dactylitis, and saw, for example, enthesitis being achieved in just shy of 50%, where there was complete resolution of enthesitis, and dactylitis in almost 2/3 of patients achieving complete resolution of dactylitis. So even though that ACR remains the primary, we collect all this other, and we really get a comprehensive picture of the impact of a drug on the disease.
And these are a tough bunch of patients that had long-standing disease. 30% had failed 3 biologics. Did you see any difference in response if you failed 1 biologic or if you failed 3? Should we still switch to a JAK if you failed 3 biologics? Was there good efficacy in both those groups?
Yes, as a matter of fact. So they, whether or not the patient had failed 1, 2, or 3, they continued to have evidence of good response. And so I would say absolutely yes. I think that it's, when I look at, say, registry data, I think it's okay if after failure of, say, secondary failure of a first TNF, meaning they have a good response initially and then lose it after a while. I think it's fair to think about a second TNF in that population, but definitely after a second TNF, I would switch to a different mechanism of action. And I think there's a strong argument even for doing so after the first loss of effect of a TNF. Now that we have more and more agents available to us, I think we ought to be exploiting different mechanisms in order to try to keep our patients in low disease activity or remission.
Excellent. And would you mind just explaining for those who don't understand it, because it's becoming more an issue with lots of trials, is this hierarchy of outcomes. And if you fail 1, then every p-value after that is only nominal. And, you know, we've seen it with the bimekizumab study, with the Finch-1 in RA. This is becoming one of those things where if you're not careful how you set the hierarchy up and you miss 1 point, the rest can't be statistically analysed without calling them nominal. Did it apply to this study too?
Yes. So there was a hierarchy where there, if one measure showed a differentiation from placebo, and in this case, the primary endpoint, which was ACR20 response, then it would march down. And these are called multiplicity controlled endpoints. And so it actually was able to achieve all of its hierarchical rows. So ACR20, then achievement are showing statistical significance for the HAQ score, then showing statistical significance for a skin score, and then a quality of life score, and then fatigue score and MDA. And so it was strong in its ability to achieve all of those endpoints.
Excellent. And I've always wondered why the FDA wants HAC as either primary, co-primary, or an important secondary, because these people have had 15 years of disease with a lot of damage. There'll be a large irreversible component of HAC. So I don't see that on the European side of these studies, but the FDA seemed to go ACR20 and HAC as the two co-primaries.
You're absolutely right. Usually the HAC has to be either in the hierarchy, either second or third from the FDA perspective. And I guess their thought is that, okay, fair enough. We want to have symptom control and patients being more comfortable, but we want to make them functional. We want to show that there's not just a impact on symptom control, but we want them functional. Maybe that's an American thing, Peter, where they want everybody out working, and so you've got to achieve improvement of function and get out there to achieve the American spirit.
I just wonder, this may not be easy to explain. I noticed that at weeks 12 and 16, the background medications could be adjusted in the patients that hadn't reached a 20% improvement. I wondered if that happened a lot or very little, and it affected the outcome.
No, it happened little. It was more in the placebo arm, obviously, and it ultimately did not have a meaningful impact on the outcomes.
Excellent, excellent. Again, very tough patients. There's a dose response. The 30 always did better than the 15. I often wonder if we shouldn't start with 30 just for 12 weeks, get them in remission, and then cut back to 15. Is there any feeling that that's even going to be possible for rheumatologists down the line, or was the safety too much of an issue with the 30?
I think that ultimately the FDA and its conservativeness is going to basically say, let's go with 15, period. And although what you just described makes complete sense, do an induction dose, bring it under control, and then cruise with 15 milligrams. If anywhere they allow 30 milligrams to be as part of the approved package, then they've got to be open to the possibility that patients are going to just use 30, period, on an ongoing basis. And so we're not as tightly controlled here as you might be in Australia, for example, in that regard. And so they've got to think about all these possibilities, and they saw that there was a higher infection rate, for example, or a higher zoster rate with the 30 milligrams. And so I don't think that that's likely. But fortunately, the 15 milligram dose is fine. I'm satisfied with that. Yeah.
The other interesting thing is, in our neck of the woods at week 12, we have to have at least an ACR 50 response to get more drug. And it was nice to see that the plateaus were out, say ACR 50 and 70 were out about 16, 20, 24 weeks. So we should give the partial responders at least 24 weeks, don't you think? I
think so, yes. So I'm a little bit, boy, that's a little there's Peter, that that you all might have the rug pulled out from underneath you on some of these drugs. There's some patients that do continue.
But these things are very rubbery.
Yeah, gosh.
Yeah, it's very rubbery. And the other, as you say, there was a dose response both with safety as well. And it even seemed to lose a bit of selectivity as you push the dose. You started to get a touch of anemia and a touch of neutropenia. So I think you're right, 15 is not too strong, not too weak, does the job nicely across the board. Two other things. Any chance that there's a breakdown of the failed BD-MARDs, going from a 17 to a JAK or a TNF to a JAK, they work just as well, there was no difference? Or you didn't have many 17s, I suppose?
Good question. And I think virtually all of the great majority of the failures were all TNF inhibitors. So I don't have a separate line on the 17.
Yeah, that's one of those things where people always ask, and it's not, by the time that study was started, it wasn't an appropriate thing. You did have a monotherapy group. Was there any difference in response, mono to UPA, combo to UPA?
Not substantially, and at least in our use of the drug, we're much preferring using it as monotherapy, and patients prefer that too, just to get away from some of the side effect issues of methotrexate.
And can you help us with Zoster? We don't have Shingrix in Australia because the US used it all up. So we have to, so we have stuck with Zostavax. That doesn't work very well. How do you guys handle that vaccination issue? Do you Zostavax them or Shingrix them at the methotrexate stage, or when you're getting into a JAK? What do you do?
So we are now much more sensitized about zoster in general, and so we're regardless of whether patients are using JAK inhibitors, we're ascertaining whether or not they're vaccinated and encouraging patients to get vaccinated with Shingrix, and we're warning them that they could get a little bit sick briefly with the medication because it packs a punch. But with the JAK inhibitors, what we generally are doing, in the old days with Zostavax, we would have them get the Zostavax before they started a JAK inhibitor. Now, that's not as clear that that's necessary. But as soon as we recommend a medicine like Upadacitinib, we are talking to the patient about going to their local pharmacy and getting the Shingrix going. It takes a few weeks for getting authorization for the new drug. So that's perfect timing. They've got the first dose in, they start their JAK inhibitor. They proceed getting a second dose a bit later, but we don't have them stop their JAK inhibitor since it's a non-live virus vaccine. And so, but we are paying more attention to making sure that they're vaccinated.
Excellent. So any take-home messages for the clinician from this study? BDMARD, inadequate responders, went to JAK, responded nicely across all the domains. Any take-home message for the clinician?
Really solid drug, not only in the musculoskeletal domains, but also in the skin domain and in a separate ankylosing spondylitis program showing effectiveness in the spine of that disease. So we anticipate it to be highly effective in PsA spondylitis or axial PsA. And from the select PsA1 trial, ability to inhibit radiographic progression. So I think it really does check all the boxes and joins the group of JAK inhibitors, which I think are going to grow in popularity and use, especially because of the ease of use of an oral medication by patients.
So thank you so much for your time, Philip. We appreciate how busy you are. This has been the CSF Author Review podcast. If you'd like to know more about this paper and read it for yourself, it's uploaded on the CSF website this month. You can get detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcast from, and give us some feedback and let us know what you think. Thanks so much, Philip.
Okay, thank you, Peter.